Hi friends, my name is Dr. Varun Deshmukh, and in this video we are going to discuss about the art of taking handover. When I joined as a new ICU doctor, I also faced a lot of difficulties, and I expect that you may also be facing the same difficulty. In my ICU also we see that many times, very often there is lapse in the handover, and that leads to a lot of stress, lot of scolding for the doctors, the junior doctors, and the incidence forms are filled, various medication errors are there, sometimes the investigations are repeated unnecessarily, sometimes the important information is missed. I thought I will make a video to try and cover this topic and probably increase your efficiency while giving or taking handover. In this video we will first discuss what is handover, what is the importance of handover, what are the benefits to the patient and to the doctors, what is the standard format of handover. In the last part of the video I will tell you a few suggestions or tips which will help improve the process, and more efficiently perhaps you can take handover. So let's start with this video. So what is handover in the first place? In simple language, the handover involves communication of certain important information, which will be probably the patient related information, and based on the information, the doctor who is taking handover can take the decisions for the patient treatment and can also be held responsible for the problems. So it is a very important, and medico-legally also it is important, and for patient care, for continuity of patient care, it is very important that proper handover takes place. So that's the introduction about handover. Now what are the challenges in handover? So when we see in our day-to-day practice, the most important thing that we see is sometimes the communication between the doctors is not established well. Probably there is a very rapid turn around of the doctors in the ICU. 6 to 8 months I see many doctors are changing, sometimes doctors come on rotation, so the communication or that link has not been established between the new and old doctors. Sometimes the new doctors are not confident, sometimes they are not knowing what information has to be given, and sometimes there is a barrier of communication and they can't freely ask, even if there are some questions which arise in their mind during the handover process. So this all leads to missing certain important parts of information, and which leads to problem in the patient care. Another problem is sometimes the multiple specialists are seeing the patient, so everybody would have advised something which may be contradictory, and there is no uniform conclusion, and while giving handover sometimes less important thing is emphasized and more important message is suppressed. So that is also one of the problem. Sometimes the patient is going to OT, or patient is going for imaging, or moving in and out of ICU, and this also leads to missing certain important information during the handover process. So these are the common challenges while taking or giving handover. Now if you effectively give a good handover, then what are the benefits? So from doctor point of view, if you say your confidence increases, your communication skills increase over the time, your stress reduces, you don't get blamed for errors. Suppose I give handover to my colleague and I go home and then some problem arises, then I am not blamed, because from my side I would have given a good handover, and because of lack of handover the complication has happened. That sort of a problem would not arise, so that will make me stress free. So probably, and also eventually the goal is to improve the patient safety and improve the outcome. So if the patient gets well, I feel good, so your overall satisfaction, job satisfaction improves from the doctor's point of view. What are the advantages from the patient's point of view? So of course, continuation of care, improvement in safety, improvement in the outcome, these are the ultimate goals. Apart from that, sometimes if you give a good handover with a detailed history, repeated questioning to the patient is avoided. Patients also get a good sense of quality service when they know that the doctors and the nurses know about the case, know about the happenings, and they are not fumbling around with the simple questions. So a good handover also increases patient's confidence and reduces patient stress as well, and repeated questioning and irritation is also avoided. So of course it is beneficial for both doctors as well as the patients. So now starting with the process of handover. So when you start your handover, who all should be present in the handover? So preferably the doctor in the previous duty and the doctor coming for duty, of course they have to be present, but preferably the nurse also should be present, the leader, team leader or nurse in charge of that shift, and preferably the senior doctor should also be present as much as possible to see what information is being conveyed and whether they need to alter or change the information. Another important thing is where the handover should take place. So I would personally prefer that ICU handover should always take place bedside, so that you can see the patient can see that the information is being handed over, the nurse can be seen, you can talk to the nurse, she can also correct you if there is any information which is wrongly being communicated. You also have access to the patient's file, to the reports, to the imaging and telephone. So you can verify or cross-check or trace any important information while you are giving handover. So handover at the bedside is probably the best according to my opinion, especially for the ICU patients. Another important thing to remember is the person who was in the duty prior, in the previous duty, has to must be knowing that which are the serious patients, which are the sick patients who might need immediate care even during the handover. So you have to identify that these are the 2 or 3 sick patients and they might require some urgent care, and you have to assign a person who will go and give the needed therapy or intervention to the patient, and all the members of the team taking handover will not rush there. So the handover process has to be continued, and somebody who is pre-assigned should cater to the emergency situation. Also, there are planned procedures in the ICU. So try to avoid keeping the planned procedure in the time when handover is going to take place, because it should not compromise the quality. Sometimes what happens is, because of the procedure, the team which was there in previous duty becomes late, and then in hurry sometimes some important information is missed while giving handover. So planned procedure should be definitely postponed, and it is a matter of maybe half an hour or 1 hour, so definitely you can postpone the planned procedures. So this is about the common sense when you start your handover. Now, what is the content of handover? So predominantly 3 type of information is conveyed in the handover. First is the information about the current patients who are in the ICU. Second thing is information about sick patients who need priority. So when the next person comes on duty and starts assessing patient, probably the sick patients or the priority patients who are in need of urgent medical care should be seen on priority, and then eventually all the patients have to be seen, but sick patients should be given priority. That is part of the content of handover. And the third is organizational issues. So like availability of your beds in the ICU, any new patients who is coming to ICU, or suppose the dialysis is going to be postponed for a certain duration, then these things also should be conveyed in the handover. Most standard format of giving handover is ISBAR, ISBAR. So this acronym stands for identification, situation, background, A for assessment and action, and R for response and rationale. So this is the acronym. It was historically first used by the US Navy for exchanging information about their submarines, and subsequently it was customized according to medical needs, and it was utilized in the medical field. So if you look at ISBAR, we will discuss one by one. So I means identity or identification. So the patient has to be identified. As per the NABH, the patient has to be identified by the name and the indot number. So first identify your patient with the name and number. Then situation. So situation means why the patient is in the ICU. So what are the medical events, what led the patient to be admitted in the ICU, whether patient came from emergency, whether patient was shifted from ward or post-operatively. This comes in the situation. Background means what are the medical background problems of the patient. So what all are the comorbidities, what is the detailed history in the past which is significant and contributory to the current situation. That is the background. A is assessment and action. So in your duty, in your shift, what is your assessment based on the background and the current situation, and what action you have taken to treat this patient. So that comes in the action and assessment. And R is response and rationale. So when you are giving handover to the next doctor, you expect them to respond to the current situation and whatever actions you have taken, and you also give them a rationale that why you want to do this, and they can also discuss the same with you, and you can come to a conclusion about the plan of further action in the coming shift. So that is the ISBAR to tell you briefly. Now we will discuss what are my personal tips to you to improve and make your handover more efficient, at the same time save your time and not miss on any important information. So of course you have to follow the ISBAR protocol and all the things that I have told you so far, but practically I will give you a few tips which will help you be more effective and more efficient. So in the ICU, when you are on duty, anticipate that you have to give handover of this particular patient to the coming doctor. So in your mind, try and summarize the history, events and other things of each and every patient in your ICU, and so that it makes you more ready when the handover is to be given. You have some structured information in your mind. So that is the first thing. So anticipate and try and summarize in your mind. Second thing I would say is to attend all the rounds as much as possible. Attend the rounds of consultants of various specialties. This helps you two ways. From the handover point, it helps you know the information and what all discussion took place when the round happened. And for your personal, from that point of view, your knowledge will improve and your thought process will become more wide and more accepting. So try and attend round. Try and discuss with multiple specialties whenever it is needed. So that is also an important thing. Fourth thing is don't keep any issues pending as much as possible. So sometimes what happens is somebody advises something, then so it may have to be confirmed with a nephrologist or cardiologist or the primary doctor who is the treating doctor of the patient. So these things add to the pending information and they create more confusion. So try and sort this out, and always try and whenever you are calling somebody, try and talk to the person who is the decision maker, and try and avoid talking to junior doctors, because it will increase the chain of communication, and the more the number of people involved, the more the chances of error or problem with the communication. So try and directly talk to the decision maker, put it down on the paper and finish the pending work. Don't keep the issues pending. So that will also improve your efficiency, and it will reduce the stress on the coming person that these many things are still to be done. Another important thing is to read all the notes written by various doctors who have come and visited the patients during your duty. So this makes sure that you don't miss on any important information. So while you are taking your round in your routine duty, try and read the notes of various doctors and build up the image in your mind, what is the plan and what is happening with the patient. And while giving handover, also quickly run through all the notes. So that will help you not miss any important or vital information. Sometimes I see that in the ICU, somebody has written something which is important, like to initiate dialysis or to plan the patient for OT or for a procedure, angiography or anything, or imaging, EEG. Some departments are they work only in the office time. Sometimes the patient needs to be prepared for a procedure, and if you are not aware of these things, then the important time is missed, and sometimes the procedure has to be delayed or the plan has to be postponed. So if you read the notes and not miss anything, probably this thing can be avoided. Another thing is talk to the bedside nurse. So whatever you are thinking, whatever your thought process and whatever the advice being given, keep on talking to the nurse who is seeing the patient. This will ensure that whatever orders you have given are understood by the nurse and she is following them properly. The nurse also may have some doubts, so she can also clear her doubts, because they also have shifts and they also give handover to their colleagues, and their handover is also as equally important as yours. And it should not happen that they give some wrong information and eventually probably in the morning you understand after the whole night shift that the important thing was not carried out because of poor communication amongst the nurses. So talk to your nurse who is at the bedside and make sure that she also understands it properly. Talk to the patient as well as patient's attendant when you are on round. This is mainly in the daytime when the attendants come for visiting the patient. So this will help two ways. So one is the patient will get more confident, the attendant will feel that they are being taken care of properly, and the other thing is your involvement will also increase when you know more information about the patient. Sometimes you just know the history, but when you talk to the patient or the relative, you realize that there is something more which is missed during the earlier summary of the patient. So talking to the relative and to the patient is always a good practice. When you are taking handover, make sure that you ask relevant questions. So sometimes the handover story keeps on going from beginning till the end, and during the ongoing handover there would be some questions which would come in your mind, and you will feel okay, I need to know this, but it's always better to ask them at the same point when they come to your mind. Sometimes the person giving handover feels that the flow is obliterated, so then note them down briefly, and once the handover is finished for that patient, ask your queries. This will also fill the gaps, and it will make the whole picture more clear, and sometimes some important thing would be missed by the earlier person, which would be covered by you, and the next the information which is given to the next shift will be better, and the patient care will improve like that. Another important thing to improve your handover is to make a list of all the pending tests and all the pending reports, and preferably the dates where they are going to come, like reports like ANA or some reports which are outsourced to other hospitals or other laboratories may take little longer time, and you have to you have to mention in your paper that these reports are pending, and probably they will come on this day or this date, and also mention which reports are to be traced in the next shifts. So sometimes there are verbal reports that the culture is growing certain, like a GNB or GPC or fungus, and probably the identification of the species will take place after some time. So in the next shift you are going to tell them to follow that up. So you have to mention what are reports that are pending and when to trace them, and when the reports are likely to come. So that will help ensure a smooth carriage of tracing the reports. So that is also very important. We cannot emphasize less on the general medical knowledge. So always remember that there is no limit to gaining knowledge, and in the initial part of your career you may feel underconfident, but as you practice more and more, as you see more patients, and simultaneously as you keep on learning and reading, your knowledge will also improve. So the better the knowledge that you have, probably you can manage the same patient more efficiently. So you will yourself feel that maybe the same patient you could have managed better had you seen the patient rather late in your career than the beginning. So I cannot emphasize less on having a good background knowledge. The last thing is to be aware of the troublemakers. So these troublemakers can be your patients, they can be relatives, and they can also be your ICU consultants. So find out who are the troublemakers. The troublemakers can cause more stress, and they can create scene, and maybe post your duty also you may be called repeatedly to ask certain things, to follow up for clarifications. So find out the troublemakers. It is a duty of the senior people as well as the old people who are working in the ICU to find out the troublemakers and guide the juniors accordingly. So there are patients who have nagging habits of finding small faults in the system and trying to criticize the way the system is working, trying to criticize the food, or so you are not responsible for each and everything. You are responsible for the medical part, and clearly give these things in the handover also, so that when the patient complains and he realizes that okay, nobody is knowing about my issue, then I have seen that the patients or relatives tend to create a bigger scene and tend to draw more attention towards their trivial problem. So try to find these troublemakers and give clear handover, and be firm in your attitude without being rude or impolite. Similarly, there are certain doctors who are senior doctors or consultants in the ICU who can also become troublemaker. So I feel every ICU has to have a strategy regarding certain things, and whatever way the ICU team is comfortable, the things should be followed that way. So these include titration of inotropes, control of blood sugar with insulin infusion, correction of electrolytes, weaning from the ventilators. These are things which are preferably be left to the intensive care specialist rather than everybody taking charge of it and calling the shots. So identify the troublemakers, choose your battles wisely, and if you feel that it is adding unnecessarily the extra stress to your work and your life, and so a little bit deviation from your way is not going to change outcome in any significant way, and probably sometimes yielding to the request or to the need can also be necessary. And sometimes if you feel that you feel strongly for something, then stand for it, unite your team, and take a joint decision regarding the particular issue. So identify troublemakers and try to be more clear and be away from the trouble as much as possible. So that's all about the handover, and I hope you liked my video, and it would have given some inputs to you, and your handover process would have improved now, and hopefully you will be more efficient in your next handover. So for more quality content in the field of critical care medicine, please like this video, subscribe to my channel, and share with your friends. Till my next video, please take care of yourself and have a good day.